Well, we just want to welcome everyone back today. Thank you for joining us in person at the March training that we did. Um, After the March training, we realized we needed to talk about some advanced workflows and documentation pieces more thoroughly. And we wanted to do that in the context of putting peer recovery specialists in the emergency departments as well as in primary care settings. So with that, we are here today. We are recording this and we will be sharing this with project participants so that they'll be able to receive continuing education for watching this module. With that, we are going to start with a video because after we went through day-long training and we've been talking to subject matter experts in this space who do this work, we realized that recovery is not a linear process. Recovery looks different for every single person. We have to meet people where they are. And sometimes people may not be ready to accept the different types of treatment available at the time it's being offered. And so we want to start out with a video, and the video does a really nice job explaining that recovery is not failure. Then after we show you this video, we're going to go into talking more specifically about those advanced workflows, documentation. We'll be talking about stigma. We'll also be talking a little bit about social determinants of health, how that could affect the patient's health, the healthcare they're receiving, and how peer recovery specialists are an essential part of addressing all the different components that we're talking about today. So with that, we are going to show you this video.
I had, from the beginning of using opiates, I was overdosing continually. That was the first time that I was, the ambulance had to call. They clearly told me they were ready to pull the sheet over me. They Narcaned me the third time, and I came to, and that was very scary. I was treated by the nurse, kind of like, because I was soaking wet and I had to undress and put on another garment. And she clearly expressed the fact that she felt like she was going to catch something from me and that I was like a diseased person. And it was a lot of guilt and shame. And I used walking home. I used continually after that.
What family members really ought to know about substance use disorders and how we've come to think about them over the last couple of decades is that it pretty clearly is an illness, meaning that there is predictable pathology, particularly in the brain, that is associated with the pathology of a use disorder or addiction. And it's often relapsing, remitting, and a chronic issue. It's actually fairly unusual for that first run at things by way of recovery to be the successful one or the one that takes.
We can try to help you to lower the risk of relapse by using these medicines, but nothing is perfect, and that's okay. We have to understand it's a process. It's not a quick fix. And I tell every patient, this process is one in which relapses are expected. Relapses are not a failing. Relapses are part of the recovery process.
But in the past, in particular, I think it was quite common to see individuals coming back again and again for substance-related issues, and for the knee-jerk response to be, "What an idiot. Why don't you just stop that?"
As physicians, pretty much by and large, we are not people who are used to failing. And we see people who have relapses as being a failure. Either I didn't approach you the right way or I didn't give you the right medications. But I think the thing that we don't take into account is that it's not just me and my treatment of you. It's really how you're going to respond to it, and then how we're going to form a therapeutic alliance and work together to help you get better. If there's a failure, it's not always because I failed. It's because that alliance wasn't there or you weren't ready to accept it.
Recovery takes time in terms of the recovery of the brain from that illness and moving toward greater functionality in life. And we know that based on imaging studies and the amount of time that it takes for recovery to occur that's then associated with improvement in function. It's not a matter of days or weeks. It's a matter of months at least.
In addiction, like with any chronic diseases, there's good times and bad times. With major depression, with bipolar disorder, there's good times and bad times. With rheumatoid arthritis, okay? There are times of active disease and there are times where it's more quiet. And the goal of chronic disease management, what's the goal? Reduce the frequency of relapses, reduce the severity of relapses, increase the duration of periods of remission, and increase the quality of life during spans of remission. That's what you do for rheumatoid arthritis and for diabetes, and that's what you should do for addiction.
What it comes down to is the rapport that you develop. And as an emergency physician, that's one thing we have to be good at. I have maybe 10, 15-minute increments to actually see patients. In that time, I have to let the patient know that, number one, I'm there for you. I'm here to help you with your problem. And number two, it doesn't matter what that problem is. Whatever you're here for, that's what I'm here to help with.
Don't give up on yourself. Don't give up on your patients. Don't give up on the system. I think the future can either look bleak or it can look very bright, depending on where you choose to put your perspective. And, nothing is over until the ultimate over. There's always another tomorrow. There's always another day. There's a chance that you will be the impact player, whether you're somebody who's in recovery, if you're a physician, if you're a nurse, if you're a paramedic, if you're a police officer. You might be the person that day who finally flips that switch and turns on the light bulb for somebody else who's going through this. Don't give up. Don't give up on yourself. Don't give up on anybody else.
If I had one message to give to the doctors and the nurses and the staff that work tirelessly in the ERs, that, they're seeing just a very small portion, right, of the person that's coming in, maybe more than once, I would say thank you for not ever giving up on me, and thanking them for not ever giving up on this person that's here right now. Because I've witnessed, even just 2-3 days ago, an amazing, the way between the doctors, the nurse, and then the social worker, they just knocked it out of the ballpark with this girl. And I'm very grateful for that.
Okay. We wanted to start with that video because I think it's really important for us to know that recovery is a process. And oftentimes when we meet patients the first time in their journey, whether that's in the emergency department or primary care clinic, they may or may not accept the treatment that we're offering them. And I think it's an important takeaway for us to be aware that they may not be ready, that this is a process, and that we have to really know and be prepared that the patient may present multiple times before they're ready to accept that treatment. So with that, I wanted to also ask you, Dr. Martin, if you could speak from your experience working in the emergency department. Did this video resonate with you? And could you talk a little bit about your thoughts on recovery being a process?
Yes, absolutely. Thank you, Kim. And I think that especially as an emergency room provider, a lot of times, even the first times that we come into contact with people, we may not be aware of all the complexities of what is going on with someone. And so having an attitude of openness and no judgment or no stigmatization gives those patients that ability to share or to be open to what we might be able to share with them. Yeah, recovery is a journey that is different for everybody. And I have patients now today that we see in our outpatient practice that remember those ER visits from before and share, you didn't give up on me, you didn't judge me, and it got me here today. And so I think one of the most important things is that we cannot treat what we can't keep alive and what we can't continue to engage with. And so what somebody hears us say and how we treat them and make them feel is so important about whether they will come back and engage with us in the future.
Thank you for sharing that, Dr. Martin. You know, the takeaway that I hear from you, as well as the video, it's absolutely critical to really engage compassionately with the patient, make them feel safe, establish that trust, so that when they are ready, whether it's that initial time of meeting the ER provider or when they come back, they're open to talk about their struggles with substances, with addiction, and ready to accept help.
Yes.
Okay, with that, we're going to now start talking a little bit about advanced workflows and processes. And with that, we're going to turn, we've got our learning objectives here today. You could see this is what we're going to be covering. I also just wanted to say thank you to HRSA. Today's recording and presentation is made possible with HRSA funding from an opioid response grant through the RCORE initiative. With this initiative, ABIN has been working with partners across North Central Arkansas to train emergency rooms and primary care settings. And we have been in the process of launching, putting peers in there. I think almost everybody has their peer who has started. And so want to say thank you to those emergency rooms as well for being our partners. Our subject matter expert, Dr. Martin, who is on here with us today. Of course, we have our own lead peer recovery specialist, Megan Copeland. And Megan is going to kick us off talking about the advanced workflows.
Thank you, Kim. Do you want me to run over the learning objectives, Misty, or we're just going to jump right into it? Jump right into it. Okay, so where do we get started? The first few things that we want to cover with everyone are schedules, peer notifications, and championing. Schedules can be flexible for this project because we always want to meet the clinic or emergency department where they're at and make sure that we're meeting the needs of the high traffic times in those clinics and emergency departments. So currently we have 9 facilities where we've placed peers, and there are 6 peers that are serving those facilities. So we have a couple peers that are working multiples, and the schedules for each of them vary dramatically. So just for example, there are a couple of clinics that do MAT clinic on specific days of the week. One of them I think is a Wednesday, so that peer always makes sure to attend on the days that the MAT clinic is happening so they can be available to see those patients. For the emergency departments, typically the nights and weekends or the higher traffic times, so that time would be optimal for the peers to work in the emergency department. So again, we just work with every facility to make sure we're hitting those hot spots and making sure we're available. For peer notifications, there's EMR notification, call, text, daily huddles, and workplace messages. So typically if a peer is in the office, they can immediately meet with I'm going to say patient because most of the people that will be attending this will be medical professionals, but for peers, we always call them our peers. So that's interchangeable, and please excuse me if I use that in a way that's not familiar to you. So if the peer is on site, they could immediately meet with the patient. And then if they are not on site, we have arranged a couple of different ways that this can work. We're always available by text. So if it's an off day, we will get back to you just as soon as we can and make sure that we can set up a follow-up or go ahead and come into the office to meet with that patient. And then there's also available by phone call most of the time. Most of the peers that are working on this is their second job. So they typically work around their regular schedule to do this project. Then go back 1 second, Misty. Championing. Got it. All good. We have asked that each facility identify a champion, and that is someone that works on the healthcare team. It may be a nurse, it may be a charge nurse, it may be an administrator, whoever is best suited to do that. But there's a lot of different criteria that we're looking for in a champion. We obviously want them to educate the other staff, to be fostering a recovery-oriented environment, someone that believes in recovery and can help advocate and reduce stigma, modeling behavior and a peer point of contact. So how do you become a champion? Obviously, we want to educate, train other staff members to understand the role, the scope, value, and the overall implementation of the peer program. It's really key to have somebody that believes in it, that has a passion for it, so that, you know, their attitude about it and their knowledge about it will be contagious to those that they work with. So the peer specialist should report out positive patient outcomes and challenging patient outcomes to that champion. So that's where the point of contact comes in. And they're also the ones that will make sure to notify the peer if someone comes in when they're off the clock. Avert organizational cultural class, medical versus recovery-oriented approaches. If we're looking at the medical model, historically it focuses on the biopsychosocial, biosociosocial. I'll get it right in a second. Stabilization and symptom management, but recovery-oriented shifts the power from being a service provider and puts them on an even playing field. We're not in a power position, and help them collaboratively make decisions. Identifying effective leader team members who are passionate about integrating peers into your organization can help you champion the cause. And address concerns early, ask questions often, respect role boundaries, speak person first language, and provide patient-centered culture. So now we're going to go ahead.
I had a quick question. This might be a good time for us to ask Dr. Martin. Dr. Martin, a question about being a champion. I know that you are a champion for substance abuse and addiction, and you have been working in this space for a long time. Could you speak when you were first starting to work in emergency rooms and start to identify addictions and start to compassionately treat them, what that was like for you? Were there any challenges being the champion for addressing addiction in the emergency room?
Yes, there was definitely challenges. I think one of the first challenges that I faced was with my peers and coworkers. That there was a lot of stigma and judgment that I faced whenever I told people, "Hey, I'm interested in doing addiction medicine," or "I really want to take some extra time to help this person out and investigate this further." There was a lot of misunderstanding, and I think people having a particular perception of a patient without knowing their full history or without recognizing addiction as a disease, or maybe other co-occurring factors like serious mental illness, or other social factors that affect how people receive their medical care. And so at first it was very difficult sometimes. And then as the process went along, those are some of the same folks who are our biggest champions whenever they can see the tremendous change that it can affect for patients and their families. Being able to really help people get to some of the root of their problems and not have as much conflict maybe between staff, or stress between staff and a patient. People that have been labeled previously as frequent flyers or super users or different things that they were frustrated with, once we actually sat down and listened to the patient and kind of talked as a team and overcame that, then it was just so much more amazing what we really learned and could do. And so it was scary at first in some ways. We weren't sure what to do. We weren't sure how to talk with people. And I think the most important thing we learned was to be open and to listen. When we listened to our patients and their families, we could start to find them solutions.
I heard that, I just want to make one last point. You said there was a lot of misunderstanding, and I don't think we can overstate enough the importance of educating the other staff members, not only about the peer, but about substance use disorder altogether. Of course, if they don't know about the peer program, they're not going to be able to refer to the peer, but I think organizations that take the time to educate on substance misuse, these programs go a lot smoother, and there's a lot more positive outcomes in the end.
Absolutely. Those are great points. We'll turn it back to you, Megan, but we just wanted to get some firsthand experience.
Absolutely. Thank you all for jumping in. That's all great information. Please feel free at any time to jump in. So moving on to peers in the ED setting, recognizing that in addition to medical care for OUD, peer recovery support can promote engagement and should be prompted early in the ED visit to maximize opportunities for discharge planning. And that might not always be possible, especially in emergency situations, but if you can get them in at some point, once the patient is stabilized, being able to make that contact is crucial. So peer utilization, it will help you prevent healthcare staff burnout. So let the peers come in and help on that level where they can relate with the person that's sitting in front of them that has that substance use issue, the peer has been there themselves and lived that, and that instant connection will be made. And you're not trying to struggle as someone that's never dealt with that to just make that initial contact. It can really help out the staff as a whole. They can build the rapport quicker. Development of crisis plans with the patient, so they can talk to them about how to administer naloxone or Narcan, and they can talk to them about what to do if they find themselves wanting to use. They can always provide their contact information so that they have someone to reach out to. Just coming up with a plan for how to prevent an overdose. Support patients during their hospital stay. They can always come back and check on the patients, and they can follow up with the patients after their discharge too, which is unique to healthcare staff. So they can follow them along their recovery journey or until they're ready to start a recovery journey. Linking patients with community-based resources after discharge. So this is something that peer support specialists really shine at, because we work in this setting day in and day out. We're all very familiar with all the different types of detox centers, the treatment centers, the resources for food banks, the resources for getting your driver's license. I mean, just those basic human needs, even that you wouldn't think of normally. Peer specialists, maybe that they need to get their driver's license back. And those are things that peers can help with as well. Expedited admittance to residential treatments. We've all got contacts at pretty much every treatment facility. So if they're saying a bed is full and you get a peer to call, you may find that there's actually one open. So that's why peers are most important. Dr. Martin, can you share, let's go back for just 1 second, Misty. Can you share your experience of how a peer has been helpful in the emergency room setting?
Sure. I think that these cover, different areas, but I think there's just so many ways that a peer can be helpful. I think, as I say, one of the things that I've seen probably be most important is they get to connect with somebody that they feel like understands them, and can have that shared experience or lived experience that they can share with them, that if they are not ready for treatment at that time or other resources, that they can still connect with them later. Being able to assist emergency room staff. A lot of times we are super busy. We've got so many different things going on and running from trauma room to trauma room, and being able to build a rapport with a patient, as far as being able to listen to them and connect with them. A peer can do that, really helps out, whether it's ER staff or clinic staff, with some things that I think really does help not only free up our time, but can connect in a better way and really help people follow through when they are ready to get connected with different forms of treatment. Real quickly, I know that, and I use this example with my own staff. I knew that there's somebody when I was the ER director in Russellville, that there was somebody that came and they gave us their number and they said, "Hey, you ever have anybody, you give me a call. This is part of their recovery process." And that was like in 2013. And I bet you that their number is still hanging in that emergency room, because it has been such a valuable resource at keeping up with the different meetings in town, what residential treatment centers are taking which clients, all those things that I may not be able to have time to keep up with as an emergency room physician, but having a peer be able to connect people immediately and effectively is such a huge asset and thing that wonderful thing that peer specialists do for our patients.
Thank you, Dr. Martin. So the next slide will move us into peers in primary care. So there's a gap in patient services given the limited time primary care providers can spend with each patient, as there is with the emergency department. You can fill this gap in services by connecting patients to peer support specialists. So peer utilization, in this case, it saves time. The peer answers questions and provides support so patients seek less time from the provider. Increased adherence to treatment plans, improved patient outcomes, improve health literacy by linking patients to those who have lived experience with navigating through the recovery journey. And then over here on the side, it says patient-provider relationship is influential to the health of patients. Actively encouraging patients to be engaged in peer support can foster a patient's individual growth and ultimately improve health outcomes. Just knowing having been the person that was an active substance user in my past, I can tell you just having someone there that understands you and that has been there before is invaluable. Like you can't explain that. You have someone that actually understands what you're going through. You're validated You're not alone. And that's the most important piece of this. Empowering patients to be more involved in their health is key across the continuum of care. Peers also serve as advocates, and if the peer or patient that they're working with is having trouble explaining what's going on with them or feeling like they can actually speak up and tell somebody, the peer can sit there alongside of them and be there to support them in those conversations. So Dr. Martin, again, what about in the primary care setting? How do you see peers? And I know that you have a primary care clinic and a MAC clinic. So can you talk to us about the peers in your clinic and how those relationships work and the benefits of that?
Sure. I find the peers in my clinic to be invaluable. I shared before, I think at other conferences, I have 5 peers that work officially in the peer capacity and some others that work in other roles. It makes such a difference for our patients. If really, and I've talked to other clinics that have done MAT and not had peers involved, and they report, decreased success rates whenever they didn't have a peer recovery support specialist involved. Our patients really engage with them. They're able to, the peers are able to help us, especially if a patient needs to maybe go to a higher level of care, or maybe they're having some mental health issues as well, or maybe just some other issues, more social issues that they're trying to get a ride to a recovery meeting or something like that. It has been a huge success for our patients, and I think is vital to, even if you can't have one full time in your clinic, to have some connections either through a recovery community organization or know who those people are in your community or county, makes a huge difference to our patient success. And it helps me. They're able to share with me and give me ideas for things sometimes that maybe I haven't thought of. So it goes a lot of ways.
Love it. Thank you. Okay, integrating the peer. So let's talk about ways that we can actually integrate peers into the different settings. Multiple pilot programs have reported that the most common factor to a seamless workflow for peer services relies on the peer being integrated into processes and structures already in place. So while they're in this program not coming on as a full-time employee to the clinics and the emergency departments, it is important to make not only them feel like a part of your team, but for the staff to feel like they're a part of the team. And so being able to identify those natural integration points is important. So we want to make everybody's life easier, not harder. So the most seamless way that we can integrate is the best way. Analyzing your existing patient flow, triage process, and discharge procedures. Look for moments where the peer support can add value without creating bottlenecks or duplicating efforts. Adapt to the environment. Peer support roles and intervention should be flexible and adaptable, allowing for quick engagement and efficient support within the existing time frame and structure. I think ABIN has done a wonderful job of making sure that we've remained flexible and working with each facility as their needs arise. Collaborate with existing staff. So fostering that collaborative mindset, using that integrated health model between peers and other clinical staff, including the nurses, the social workers, and the physicians. Encourage open communication and shared understanding of roles and responsibilities. So that's another piece that's just so important, is for that champion to educate the others in the workspace, because if people don't know who the peer is or what they do, they're not going to make those referrals. So the more that we can educate everyone, and then also educate the peer on what's going on in the healthcare world so that we can better understand and find where we can fit in best.
I wanted to call on Dr. Martin again. We're putting you to work today on your lunch hour, aren't we? But to adapt to the environment. I think it's important because historically speaking, medical, it's 8 to 5, this is your shift, this is what you have to do. But for peers, it's different. Like you said, they may take them to court, may take them to a recovery meeting. So what does just being able to think outside of the box and let the peers do what the peers do, how does that look in your clinic?
So that's a great question. I think it looks differently for different people. I'll be honest, I try to really empower my peers to not micromanage them. I think each one of them has a gift and a passion that they like to serve. Some people really love to work more in justice involvement. Some people really love to work more in the clinic side, and so we really allowed for some of that flexibility. And yet, we all know that whoever they're working with may need any of those services at any time. One of the things that I do with my staff is certainly we have typical hours that that we have them in the clinic, but if there's something special they need to do or something that we need to be supportive of, either through training or flexibility some way, we try to allow for that. Because you're right, our patients or their peers crisis doesn't always happen 9 to 5, right? And I think also being able to allow for them to share their passions and engagements lifts them up to be kind of experts in their areas. Maybe somebody who's been justice involved before can share with me and the rest of the team how best to work with the drug courts or how best to work with somebody that's in a reentry program or things like that. So we really try to have the open dialogue and just like we would our patients, asking what their needs are and listening to them, work with our peers to get pretty continual feedback on how we can improve or what we can do to support them so that it's a constant conversation. Yeah. So
Awesome. Thank you.
Okay. When should you call a peer? So peers are best utilized by leveraging their lived experience, communication skills, and empathy. So during pre-hospitalization or triage, if you notice that the patient is currently under the influence of a substance, you could call in a peer. If they're there because of an overdose, obviously you could call a peer at that point. If they're self-reporting that they have an issue, if there's other medical concerns that could be caused by substance use, those are all great times to call in a peer. So during treatment and care. So if maybe you're in the exam room with the patient and during that time they start talking about some substance use issues, then you can always call in a peer at that time. When there's a break in the action, waiting for the physician, x-rays, labs, or being ready for discharge. So there's always that lull time in the ER, right? When you're waiting for some test results to come back or you're waiting for those discharge papers. Those are great times to let a peer come in and they're not messing up your regular workflow. And we're just really capitalizing on that downtime. After triage is complete, waiting on the physician. Part of their role is to help identify patients that may have issues with substance use and engage accordingly. So maybe it isn't someone that has said anything about having an issue, but there is some downtime. They can just go in and introduce themselves to those patients. And you never know if they have a family member that may be suffering, that they can be a resource for them. Or if there is something that is not even related to the doctor's visit going on in their life where they may need a peer. Recognizing appropriate opportunities. So we just expand on that here. So SUD mental health concerns, if there's an overdose, intoxication, withdrawal, anxiety, depression, those chronic health conditions that may be related to SUD, such as HIV, AIDS, hepatitis, diabetes, hypertension, or cardiovascular diseases. If there's high-risk behaviors such as needle sharing, unprotected sex, legal issues related to SUD, if there's homelessness or unstable housing, again, when you think of a peer, don't only think about substance use. There's ways that we can help those that are just not having their basic needs met. Social support, relapse prevention. Recently discharged from SUD treatment, if they're lacking social support, maybe they have no family in the area, they don't know who to turn to, a peer can be that person that they can lean on and that can guide them through their process. High risk due to environmental triggers, social pressures, or lack of coping skills. So maybe it's someone that you know is trying to get into recovery, but they're still living in that house where drugs are being used. Connecting them with a peer will open up many options for them for transitional living facilities or other opportunities. Engagement and motivation, expressed ambivalence or reluctance to treatment. So you may have that patient that you know that there's some serious stuff going on with them and they're just not ready to talk about it or admit it, or they're just acting like it's not really a deal. If just making that connection with the peer and that lived experience sometimes can be the spark that's needed for them to open up and share what's really going on. Unsuccessful attempts to quit or reduce use in the past. Education and harm reduction. So peers are great at coming in and talking to families that may have someone that's struggling. They can also be guidance for accessing community resources, like we talked about, support groups and treatment options in the area. And we can also come in and educate the healthcare staff and the patients on stigmatizing language and how to break down those barriers. Okay, role clarity. A peer recovery support specialist is and is not. So I think we've pretty well covered what we are. We're people with lived experience. We encourage, support, praise. We function as an advocate, support many pathways to recovery, role model for positive recovery behaviors, share knowledge of local resources, and motivate through hope and inspiration. But most importantly is what we are not, because we never want to practice outside of our scope or be a harm to anyone. So we never provide case management services. We do not give professional advice. We do not use clinical language. We do not diagnose, assess, or treat. We are not an expert or an authority figure at all. We want to maintain that same level of, like we're on the same level as they are. Mandate tasks or behaviors and tell a person how to live their recovery. It's not our job to do things for people or to tell them how to do things. We just share what works for us and give people options.
Awesome. Thank you, Megan. I think we're going to give you a little bit of a break for a minute and ask Miss Kim. We're going to go over some of the different workflows and documentation pieces. Whoops. I am eager apparently to get through this, but so anyway, I will give it to Kim.
Thank you, Misty. So, you know, when we're thinking about workflows, workflows are helpful because they help us look at a systematic process that we do the same way to help identify those patients in need. So we know that a brief screening is really important in this model. Sometimes in the emergency room, that might simply be one of the questions that is asked while information is being gathered and that patient's being triaged. Oftentimes there's a single question screener that's asking about, have they misused substances or prescription medication at any time? And if they answer yes, then that is a positive. We can then look at different screeners that have been validated and are often used. The CRAFT and the Audit 10 or the DAST are common screeners that we see. Primarily, we see these screeners in the primary care setting. With the audit, there is a 3-question screener that's also an option. You'll hear a lot of talk about SBIRT. SBIRT is an evidence-based model that SAMHSA supports, and that means screening, brief intervention, and referral to treatment. So you can see there's the screening piece, and then there's a brief intervention that can happen in the emergency room. Next slide. This looked really nice. You could see this is from Massachusetts Medical Society. They came up with this workflow. So they identify a patient with a positive screening for substance misuse. You heard Dr. Martin say sometimes the patients may not be identified initially at their visit, and so it's important for us to really be aware. One of the things that I have heard often in healthcare and am also have experienced, if people don't ask us, we don't tell them, right? So if someone's not asking, are you using substances? Have you misused substances? Have you misused prescription medication? Have you used any prescription medication that was not prescribed to you? Sometimes we don't know to offer and volunteer that information, especially if we don't see it as a problem. If someone does have a positive screen, it's important that we look and ask about withdrawal symptoms. Sometimes they could be presenting to the emergency room because they are having withdrawal symptoms from opioids. They can feel really bad. And it's important for us to know that. If someone's struggling with an acute issue, and they haven't been able to access substances, that could also be contributing. And the longer that they are there with you in the healthcare setting without access to a substance, the more likely we are to see them in withdrawals. There are a couple of great screeners out there. One of the things that I liked about this particular workflow is when somebody is identified, they develop a best practice alert. So the best practice alert populates to the nurse as well as the provider. And they're immediately notified that this patient is struggling with substance misuse, and they move to a assessment process to look for is this person in need of some type of medication and or other type of intervention. This is a great time when this alert happens. This is a great time to also notify the peer recovery specialist so they could possibly assist and be looped in as part of the process working with the patient. Next slide. Documentation. Documentation, of course, is such a critical component of what we do in any type of healthcare setting. If we don't document it, it didn't happen. And we wanted to just provide a couple of short examples of documentation. Sometimes it's easy if we have these scripts that are available in the EHR, and we can turn this into a checkbox, and then you could easily talk about what you did with the patient. The patient was at no risk, they were at an increased risk, and the patient was not interested in discussing this. Check the box. We now know you attempted to engage talking about this with the patient. It's really important to know that there are ways to screen for the assessments. Medicare and Medicare has turned on codes. And so it's important for us to know that oftentimes these services, we can get reimbursed. And this gives us an example as well of the referral process. I think it's great if we could talk about after the brief intervention, did the patient, after we're using motivational interviewing, did they agree to use, or excuse me, to abstain from use? Did they accept a referral to a treatment center, to outpatient therapy? Are they willing to start a medication? And so it's really important for us to know. One of the things that I also think is essential, and we were at a conference just this Saturday, it was with the Arkansas Psychiatric Association, and the focus was on addiction. Oftentimes, now I'm losing my train of thought. Oftentimes it's essential for us to use motivational interviewing. Motivational interviewing has been identified as the most effective type of intervention that we could use with patients. And it can be very brief interventions. And so want to know that every opportunity we have to engage with patients and talk to them about substance misuse, we can make impactful changes by talking to them using motivational interviewing skills. Next slide. Here's just a couple of examples of withdrawal scales. The Provider Clinical Support System, PCSS, they modified the opioid withdrawal scale. And so we have it up for you and you can review that at your leisure. Next slide.
All right, I think I'm gonna give you a break for a minute and talk about still remaining with documentation, but obviously keeping everything confidential. You know, when we originally did this training, peers were on here as well. So we wanted to make sure everybody knew what qualified as personal information. And I think even more so with substance misuse, I know there's a lot more to it with the, I think, CFR 42. So there's a lot of different who you can, who you can't talk to about everyone's thing or about everyone's information. So for this particular project, for that reason, we want to make sure that we're obtaining a proper consent. Once the patient is stabilized, we want to make sure that they consent to being or to either A, talking to a peer, or B, letting the facility give their contact information to the peer. And there's several different ways that can happen. If it's possible within your EMR, one of the easiest ways is there's a lot of times you could I don't know which, everybody does different DMR or EMRs, but there's ways that you can add it. I know a lot of them have a box that simply says other, and you can put the peer in there. We have developed a hard copy, patient consent, if that is something that if these things are not possible with your EMR or you just prefer a hard copy, we're happy to provide that as well. We're also collecting, obviously we've got some grant reporting that we need to do, but we also wanted to take it a step further and collect some, oh goodness, excuse me, there I go again. Some data for hopefully to help with sustainability after the grant ends. So this is not reporting that the healthcare facility is doing. This will be all through the peer. But those are the different type of things that we'll be collecting from the patients. This leads us, the continuum of care kind of leads us. I know we've already talked about meeting social needs, and that the peer is kind of like a broker in linking services. So I'm going to give it back over to Kim to hit some of the SDOH, social determinants of health pieces, and all the
Awesome.
things that the peer can do.
Thank you, Misty. You hear us talk a lot about social determinants of health, and I think it's really critical to know that oftentimes social determinants of health are really impacting the individual. And when they come into the ER, they come to the primary care setting, they are not just bringing the health symptoms, but they're bringing all of the different social determinants of health needs that they have. They might be unhoused. They might have food insecurities. They might be struggling with access to adequate mental or physical health care. Maybe they're struggling with transportation issues and they cannot get to their healthcare appointments. Oftentimes we're hearing that, especially in some of our rural areas, there's often not public transportation that's available for them, and this can be a struggle. If someone has legal problems, maybe during their addiction, they incurred charges, they're bringing that legal history with them. That could be a source of stress. They may not have a job, and it may be difficult for them if they've had felonies to try to find employment. They might not have access to the training and education that they need for the different types of jobs that they might be interested. So I want to just remind everyone, we just actually did a presentation last week on social determinants of health and how it's absolutely critical that we are aware of all of the different components that are coming in with the patient to the healthcare setting. Next slide. Well, saying that, I think it's really important for us, as you could see when we look at this wheel, that the largest influences on our health are not clinical care. And I'll just say, for me, this was surprising because oftentimes we think about, well, does someone have access to care, and do they have quality health care? You could see the largest components are the social and economic factors. So do they feel safe in their community? Are they able to go outside and, walk in their neighborhood, connect with other individuals? Do they have positive, energizing social relationships with supportive people? That's absolutely essential. Income, employment, education. You could see on the bottom, the second largest category that affects health influence are health behaviors. And so, of course, alcohol and they have it identified as drug abuse. We're starting to change our language and move towards substance misuse. Substance misuse directly affects our health, and it has a great influence on health behaviors or the actual whole health of the individual. So it's really important for us to know when the patient is coming into the healthcare setting, we have to be aware. And as we're learning from the patient about their symptoms and what they're struggling with, it's important to also hear their story so that we know how can we best help them. Next slide. I thought it was important for us to talk a little bit about cost, because we know that managing cost is an absolutely, essential part of what we're doing. And so when we're thinking about how can we decrease costs in our emergency rooms and healthcare settings, it's important for us to know. You could see about more than 50% of hospital readmissions are due to unmet social determinant of health needs. There's a cost of about $200 billion, and we see 4.3 million preventable emergency department visits with about 30% of those as unnecessary visits and 86% of chronic health spending overall. Next slide. On this slide, you're going to see the average additional cost to an emergency room if someone is struggling with a mental health / substance use issue. And you can see that cost is upwards of $2,264. We know patients that are struggling with mental health and substance use are often coming to the EDs because they're having acute symptoms and they want a quick fix. They want something short term to ease the pain and ease the misery of the symptoms that they're feeling. Next slide. With this, I think it's really important for us because we identified substance use disorders as a chronic condition. You heard in the video, and you've heard from Dr. Martin, it's important for us to look at addressing substance use disorder as a chronic condition. You can see here's a list of chronic conditions, and you can see the prevalence from a population health lens. We're just going to use, let's go ahead and we'll use asthma. About 3.7% of the population is struggling with asthma. We see the annual cost is $9,810. However, if we add a co-occurring disorder such as substance abuse, we see and 29% actually of patients with asthma are struggling with a behavioral health condition like substance abuse. You can see the cost goes up 141% of treating that patient. So as we're thinking about why should we bring peer recovery specialists to our ERs, and thinking about substance abuse as from a chronic disease model, it's really important to know the cost of patients that are currently coming into your ER with unidentified and unmanaged substance use disorders that have co-occurring chronic conditions can be causing astronomical costs. If you're able to identify those patients and if you're able to provide them with resources they need, we know that you're short on time. We heard Dr. Martin say, we heard, in the video, there may be 10 to 15 minutes to try to establish rapport, identify problems with those patients. We can have the peer recovery specialist come in and they could be a support and they could walk with that patient through the start of that recovery journey. And that is going to have an overall decrease in cost for patients coming into your emergency rooms. Next slide.
That leads me in beautifully, Kim. Oftentimes we can't talk about substance misuse without talking about stigma, right? And I know we've mentioned it several times throughout the presentation, but I think it's, important to be mindful of that, because it is definitely, it happens in every facility. No one is immune from it. It's from the World Health Organization states that it's the most stigmatized health condition in the world. So again, that's where the peers can use their lived experience and help with these individuals, because they come as no judgment. And obviously, it's rooted deeply in our society that it's a character flaw, right? Or a moral failing. When we saw the video earlier in the presentation, a couple of the physicians touched on that. But we know that that is not the case. It's a treatable mental health condition that affects a person's brain and behavior, leading to their inability to control the use of substances. So just trying to, be mindful that it's alive and well, even if you're the champion or if you're not. Maybe you don't show stigma, just be cognizant that possibly not everybody else in your facility thinks like you. And there's a few ways we can help combat stigma. And the number one way to help combat stigma is to normalize it. And again, this is where you utilize the peers. When you share lived experience and someone sees that they went from this to this, they put a face to it, right? You're not a number, you're not a statistic. They see that it can actually happen. It's also important to examine yourself, right? We all have biases. None of us, whether, we all grew up thinking certain things or have acquired different beliefs throughout the years. So just taking, just checking yourself and paying attention to the way you think can kind of help not perpetuate. Show compassion. Let's empower rather than shame. We all have a story, right? It might not be with substance misuse, but everyone has a story that they're not proud of. I can promise you that people who are struggling with substance misuse did not set out to have this issue, right? And we know also that trauma plays a huge role in those with substance misuse. So just showing compassion and kind of, like Dr. Martin and Kim said, that dialogue, right? Listening, taking the time to listen and see what, where their hurt is, what their story is. Support and include. Since it has been forever that we think it's a moral failing, it's important to take a look at the language, particularly in institutional settings, and make sure that the language is that we're not continuing to use words like addicts and junkies, and just update. Let's update and or update our language to empower. And then we've also talked about this: learn the facts. Take the time to learn about the science of addiction and trauma. And then once you learn something, take that knowledge and share it. Don't be the one that just nods and smiles, right? Challenge the myths, challenge the stereotypes. And then obviously our words. This is probably the easiest thing that we can do, is be mindful of the words that we use. People with substance use disorder that's not who they are, right? That's a condition that they have. So it's important to use first person language and let them identify who they are. So instead of junkie or addict, we're going to use person with substance use disorder. And former addict or ex-addict, we use person in recovery. And I'm not a peer, but I'm also a person in long-term recovery. And that's even hard for me, so I get it. I have to be mindful when I'm talking about my past to not use some of this language as well. It is a disease. It's not a drug habit. Return to use versus relapse. And then for healthcare facilities, screen tests, like when you're screening them, clean or dirty versus positive or negative. Patients hear a lot more than what you think. They hear you discussing out in the hallway. They hear what you're saying about them or about their situation. So just being mindful of your words will do wonders. All right. So as we finish up here, we want to again point out that recovery is not linear, right? They may continue to come in over and over and over until they're ready, and that's okay. Substance use relapse rate is very comparable to the other chronic health conditions, so it's not unusually high in comparison. And the end goal is not going to look the same for everybody. I'm sorry, my son is screaming in the background. I'm at home, so I'm hoping that y'all don't hear him.
Misty, we can't hear anything, so no worries.
I'm like,
You're doing great.
So yeah, the primary goal of any peer interaction is to establish a relationship, to build that rapport. Because again, they may not be ready, but when they are, they know who to contact when they're ready. It's also important to note that peers do not promote abstinence. They don't promote any pathway. There's several pathways to recovery, and Megan can talk more on this. But the goal is to have a better quality of life. Like Dr. Martin said earlier, you can't fix someone that's not there, right? So you've got to sorry. Sorry. I lost my train of thought.
You're good, Misty. Let me help you out a little bit.
Yeah,
So
please
I
do.
love everything that you've said, and you've really hit the nail on the head talking about how recovery is not linear. It's not going to look the same for everybody, and there's going to be ups and downs that may sometimes include relapse in it, but it doesn't necessarily have to. I think the main goal is that we are available for people, that we do not shame people, and that we're giving them an opportunity and a path out of it. The end goal and final workflow step of peer support within the ED and PCP setting may take a variety of forms. So we may come in contact with a patient or peer that is not ready to get clean at that time, and that is okay. That we're still going to be there for them. So if there's causes that you're running into or those frequent flyers, peer support is the key here to making sure that we're giving that person an opportunity to live a fulfilled life. Okay, key takeaways. Do you want me to take it away, Misty?
Yeah, I mean, you're welcome to.
Okay, key takeaways. Champions are going to be critical to encouraging providers to use peer services with their patients and to form trust with peers. So that champion is our key piece here. We got to make sure that we have somebody that's educated, that's passionate, and that's willing to help integrate the peer support specialist. The role of the PRSS, which is peer recovery support specialists, is meant to complement and enhance the work done by the existing members of the treatment team. We're only here to make your lives easier, to make the patient's life better, and just to promote recovery. Contact the peer recovery support specialist as early in the process as possible to initiate services. So again, we know that sometimes there's high priority traumas that come in that it's not a good time for us to come in. And we don't, I mean, obviously if the person's actively in an overdose, there's not much we can do, but once they are stabilized or they have calmed down, it's a good time to bring us in and let us try to make that connection. Educating providers and other staff members of the peers' role is crucial to the success of the project. SUD is a chronic medical condition that is best addressed in the medical setting. And this integrative health model, we can all come together and play our part and make sure that people are getting the best care possible.
Nicely said. Thank you, Megan.
You're welcome.
I did want to point out a few things. We sent out an organizational survey that literally takes probably 1 to 2 minutes. It's only 5 questions that will help us after the end of the grant. So if you haven't done so, please hop on there and take that. If you need the link again, please feel free to reach out. I'll be happy to send that to you. And then, of course, we've mentioned the recordings that not only the partners of the project can watch, but also your other staff members are able to get on and watch this recording along with, I think, the 5 others. So with this, there'll be 6 total recordings equaling 7 hours of CEs available. So great way to educate the other staff members if they have time to get on there. And then also, we want to know that ABIN's here throughout the project in any kind of ongoing support, technical support. You have questions, anything that we can do, please feel free to reach out. We want this to be successful, and we want a lot of healthy, positive outcomes to come out of this. So please feel free to reach out at any time. Oh, and with that,
Why don't we check in to see if we have any questions?
yeah, let's see.
I think that it's everyone's autopilot. There's not actually anyone present, so
Sure.
There's probably not going to be a whole lot of questions.
No worries. You know, that leads me really to ask Dr. Martin. Dr. Martin, do you have any suggestions, feedback, key takeaways that you would want to give to care teams as they're getting ready to embrace peer recovery specialists and start identifying substance misuse maybe earlier or more aggressively in their clinics?
Sure, thank you, Kim. I appreciate that, and wonderful job to all of you all for what you all have put together. Each time we talk about this subject, I'm always impressed by your educational pieces. I think for me, one of the things that I always think of, just as far as for providers and peers in general, is just remember that each time we have contact with a patient or their family, or even people on our own teams, that they are all touch points. That's a word I really like, that it's all touch points in the continuum of care. And we never know when that opportunity, when those kind words or that understanding is going to be it changes somebody's mind later, or what is that key moment, even if they don't verbalize it at that time. I think another thing is just don't let the process be overwhelming. If you can just start with one thing, just take one step. We ask our patients to do it all the time. Hey, if you could just do this one thing this month, or make this one change, that one change, then over a period of time, and then next month, maybe add a second change, or when you feel comfortable with the process, adding something to your program. Each of those changes can be positive and produce positive outcomes. So don't be overwhelmed by the process, but just start with something that you feel like everybody feels most engaged in or is excited about. And maybe pick something as simple as offering naloxone training to people that are on chronic opioids, or something else that is a simple screening tool, something that can start a conversation that doesn't have to be anything that is creates a fear base or anything, but makes it a normal part of your process. Just like we used to ask about smoking, we'd say, "Oh, do you smoke cigarettes?" And now we know that that's secondhand. That's nobody questions if you ask them about their smoking. Now they expect it. Finding something that you can do that way is a great way to normalize it. And so I think just be open, be creative, ask for help, ask for questions, because we are here to help anybody who wants to start or move along in this process.
I really think once they get that first result, right? Once they hear back from the peer from the first time that they've saved a life, or someone went to treatment, or see the incredible positive outcomes that peers bring, I really think it's a lot easier to gain momentum because you see that you have made a difference. So be on the lookout for that. Ask your peers.
Absolutely. Well, I just want to thank everyone for their time today, for their attention. And I have to say, I am so excited to watch the positive results of putting peers in the emergency room. We're gonna see those outcomes over the next 6 months. And a key takeaway for me is it's really important for us to identify and acknowledge that the peer recovery specialists are part of our care team. And we know that team-based care is absolutely essential to providing optimal care in health settings. So please know you have this resource on your team that is there to support your work and to meet individuals where they are as they start this recovery journey. So with that, don't hesitate to reach out to us. You can email anybody on our team, and we hope you have a wonderful day. And thank you, Dr. Martin, for all of your input and sharing your personal experience, because you're there, boots on the ground, experiencing this work.